Hello, my name is Deontay Marquis. I am a family nurse practitioner, and today I will be your instructor for the next hour as we will be discussing how to improve management of patients with chronic obstructive pulmonary disease. And I will be presenting to you on the next hour this topic on behalf of my ALF training. Um, a few of our course objectives for today, and these are the things that we're going to be focusing on, that at the end of today's presentation, we will be able to check off each one of these little boxes because you will have the understanding of each one of these objectives. So let's see what we'll be talking about today. So at the end of today's presentation, you will be able to understand what COPD is and how it affects the respiratory system. So we'll get a little bit into anatomy and physiology, learning how things are supposed to work, and seeing how COPD affects them from working as they should. Next, at the end of this presentation, you will be able to discuss and understand COPD signs and symptoms, specifically those that we see more commonly, and you will be able to recognize those in your practice. So that is very important to understand signs and symptoms because some of the patients you're caring for may not have a diagnosis of COPD, and you may be the first person to notice them presenting with signs and symptoms that would dictate a diagnosis of COPD. So I'm gonna give you guys that knowledge so you'll have that knowledge and power to be confident in assessing your patient and saying, this seems a lot like COPD. Let me inform the doctor or let me inform the nurse or the charge nurse. And third objective, you will be able to identify limitations of COPD and nursing considerations to help your patients work through those limitations that this disease has placed upon them and impacted their lives. Um, our fourth course objective for today, you will be able to discuss the treatment options for patients suffering from an acute COPD exacerbation. Now, this is very scary. I'm not sure if you have witnessed this before, but COPD exacerbation is very scary. We'll talk about what that looks like, how it comes about, and what you can expect during COPD exacerbation for your patient and how we can help them. Knowing our treatment options, knowing what we can do in this situation is going to help you stay calm. It's going to help you transfer that energy to your patient so they can try and stay as calm as possible so you can help them work through an exacerbation of their COPD. Our fifth course objective, you will be able to discuss the relevant side effects of medications administered to treat an acute COPD exacerbation. And when I say relevant side effects, I'm talking specifically those that are more common. Again, we want to know what's most common, and we will deal with the rarer side effects as they come. So specifically relevant side effects, those that would affect the patient's heart, cardiovascular system, and of course their respiratory system. Some of these medications will affect the patient's respiratory system as well. So we want to know those specific relevant side effects. And our last course objective for today, identifying nursing interventions to improve overall daily life and disease state. So how can we improve our patients' daily life and slowly halt the progression of COPD from entering into more significant stages that place even larger restriction on the patient's ability to go about their daily life and to enjoy life without always having to be held back by their disease. So I think it's important whenever we're providing care for a patient to try and understand what they're going through, what it feels like to have that disease. And that gives us a better input on how we manage their care and how we look at them when they're telling us that they feel a certain way. So, um, this is an excerpt taken from a interview of a patient who had COPD. So, I want to play this for you because this really demonstrates what patients with COPD struggle with on a day-to-day basis, not just their problems with breathing, but also the emotional difficulties and how that can affect their lives. And this will help us tailor our care to this specific patient and become better healthcare providers. So let's take a look.
There's some days that I feel like I can take on the world. The breathing's not that bad. There's other days that no matter how much treatments I give myself, I just can't seem to catch my breath. It's like somebody put duct tape over your mouth and your nose and just cut a little hole and you're breathing through a straw. That's all I want to do is breathe. Then something as simple as getting dressed just wears me out. That can take up to a half hour to get dressed, just putting on a simple t-shirt, pair of jeans, going to barbecues, having this fireplace lit. Can't do that anymore. It's very hard for me to go out and have a good time. I'm always afraid that if I laugh, I'll go into a coughing fit. Oh, the pain. I've lost out on a lot.
Okay, I'm going to stop it there. Um, so, what did we see in that video? We saw the patient, Miss Jan, struggling to catch her breath without doing any activity standing in the kitchen. She told us about uh, how it limited her ability to even laugh. She said she was afraid to laugh because it may trigger a breathing fit, as she called it. So she didn't want to laugh as much. So you can imagine how her social life is, how that's affected her personality, and possibly you can even imagine how that may have led to some depression in her life. But what really stood out in that interview to me was how she described living with COPD. So I used that excerpt here in this slide, Life with COPD. And she said, it's like somebody put duct tape over your mouth and your nose and just cut a little hole and you're breathing through a straw. That's all I want to do is breathe. So that was a very impactful statement from her that I wanted to share with you. So moving forward, we can understand why this presentation is important and why being able to help these patients is important as well. And the reason for this presentation as we move forward here, so we can use these skills and tactics in our care to improve these patients' lives. So, COPD, hiding in plain sight. What does that mean? Well, that means that in the year 2019, the Centers for Disease Control published an article about how COPD was literally hiding in plain sight. So, chronic lower respiratory disease, primarily COPD, was the third leading cause of death in the United States in 2014, with almost 15.7 million Americans reported that they have been diagnosed. While more than 50% of adults with low pulmonary function, so that means that they probably went to the doctor with complaints of shortness of breath and were tested. And the test showed that they did have a low pulmonary function, so they weren't breathing at the capacity that they should, but they weren't made aware that they had COPD. So the actual number of Americans who may have died with COPD is likely even higher. And those people, those 50% of adults who were told that they have low pulmonary function may have likely had COPD, but if they haven't been diagnosed and they aren't on the proper medication, so we can just imagine the frustration and the uh, struggle that they were having in their life living with COPD, as we saw Jan is, but without any support or medication. So, what is this terrible disease? What is COPD? COPD actually, COPD refers to a group of diseases that, uh, to put it simply, cause airflow blockage. And of course, if there is an airflow blockage, then that's going to cause different types of breathing related problems, which primarily includes emphysema and chronic bronchitis. So, this is what your lungs look like when they're healthy. You see the bronchial tube, so the air comes here, passes through in through the mouth, down the trachea, fills the bronchial tubes, and then enters into the alveoli, which are the small sacs at the end of the bronchial tubes. The air moves down into the lung in these bronchial tubes. It expands the alveoli and collapse as we breathe out. Deep down, all these branches, these bronchial tubes branch all throughout the lungs, right? So the air comes in and everywhere is supposed to be full with air when we take a nice deep breath. And then from there, the oxygen that we breathe in goes from the air sacs, and the oxygen is absorbed through the air sacs into our blood. And that's how we oxygenate our blood and our body. And then carbon dioxide moves into the air sacs from the blood that has already been used, and that's what we exhale. So this is your lung healthy, functioning, um, a healthy lung. Now, what makes it so hard to breathe? Patients with COPD, as we saw in the video, Jan was struggling to catch her breath just standing up in the kitchen. Um, Now, alveoli, they lose their elasticity, um, and this makes it hard for them to exhale. So, if the alveoli is losing the elasticity, then that means it's not expanding to the capacity it should. It's not filling with the amount of air that it should. And that means that we're not getting as much oxygen into our lungs as we should. And then when it's time to exhale, that air actually gets trapped in the lungs because the lungs aren't closing. They don't have the elasticity to snap back and push and push the carbon dioxide out. The bronchial tubes from the bronchitis and different breathing related problems start to become inflamed. So when something becomes inflamed, it swells and starts to narrow. So those tubes are narrow. So that means even more air isn't getting in. And also thick mucus develops that causes the chronic cough associated with patients with bronchitis. So patients with bronchitis and emphysema are at a high risk for developing COPD. And those are actually the diseases that lead to COPD. All right. So the COPD patient, what does the COPD patient look like? Well, the COPD patient, I'm gonna let you guys read it here, is a smoker, former or current, has asthma, has likely worked in a hazardous or polluted work area, is age 65 or older, is likely female, and is likely American Indian, Alaskan Native, or a multiracial non-Hispanics. So this is the profile most associated with patients who have COPD. Uh, they usually are smokers or someone who worked in a hazardous or polluted area. It's most likely females, or more likely. And as age increases, at age 65 years or older, we're more likely to develop COPD. And it is also specific to ethnic groups, as we see here: American Indians, Alaskan Natives, and multiracial non Hispanics. So, what effects does COPD have on these patients? So we know we have an idea now what COPD is. We have an idea about how it affects the lungs. We talked about how COPD patients, they have mucus in their lungs, narrowing of the bronchial tubes, and they have lost elasticity in the alveoli, the small sacs at the end of the bronchial tubes. So they're not able to take in as much oxygen. They're not passing as much oxygen through their body. They're not able to expel the carbon dioxide. And on top of that, they have mucus building up. So they have a lot of problems going on. And on top of that, they also have inflammation. So, what type of effects, if those things are going on inside of our lungs, what effect would that have on a patient who has COPD? So, if you have a COPD patient, they're probably going to be short of breath. And if they're short of breath, then they are going to need oxygen. And if they need oxygen and they're short of breath, and they're going to have activity intolerance. They're not going to be the patient who's moving around, who wants to walk outside often. They're going to be the patient who is sitting down, who has an oxygen tank, um, who is a little socially withdrawn. As we saw in the video, Jan was a woman, as she said, she didn't want to laugh as much. So if I'm always short of breath and I'm afraid that it's going to, me laughing is going to possibly trigger a my COPD, then I'm gonna want to stay away from people and just keep to myself because I'm sad about that. Someone who can't laugh. That's a very sad, um, very sad statement from her. They're also going to be someone who's weak because of the activity intolerance. And last but not least, excessive phlegm. They're going to be coughing and have a lot of phlegm because of that constant irritation and inability of the lungs to expel fluids because the alveoli have lost elasticity. The narrowing of the tubes, it's going to be more difficult for them to bring up mucus. So oh, lightheaded. Also, someone who's lightheaded, but as you can guess, because they're not getting in enough oxygen and they're holding on to a little bit of that CO2. So that's going to cause them to be lightheaded. So, how can we help them? What should we be doing to help um, a patient with COPD? What is our management goal of this patient? Well, the patient who has COPD, our management objectives, I have put together 5 specific care goals that we should have that should navigate our treatment of this patient, our care for this patient, and also we should go under each one of these and set care goals for this patient. So we want to have a way to track their progress towards achieving better management, better quality of life, um, and the progression of how our management is improving, or if their disease state is staying the same. So these care goals, the first one is we should assess the patient, talk to the patient, and figure out what symptoms are they having that's affecting their lives the most. Perhaps this patient is coughing a lot and is has a high activity intolerance. So they sitting in the wheelchair or sitting on the couch or on the side of the bed, coughing a lot. They always have mucus. So they always have a cup with them because they need to spit to expel the mucus. And they have a high level activity intolerance. So they have their oxygen with them. They don't want to walk. They're starting to become obese because of this activity intolerance. So first, we should look at for this patient what we can do to increase their activity intolerance and what we can do to um, relieve their excessive phlegm. So that would be the goals we would set under number one. Now, two, prevent disease progression. That would be our second most important uh, management objective for the patient. is we want to prevent their disease from getting worse. Now, how can we do this? We'll talk a bit more about that later on in the presentation. Three, reduce risk of mortality. Uh, I showed you guys the article by the CDC in one of the previous slides, COPD hiding in plain sight. And it said that COPD was the third highest cause of death in the United States in 2014. So this patient is at a high risk, and that risk is associated because patients with COPD, as we said, they have activity intolerance, they're not moving around as much. This makes them weak, this makes them obese, and this just increases the incidence or the likelihood that they will eventually pass because of this disease and the comorbidities that it brings with it. So, we want to reduce this risk of mortality. We want to increase their activity tolerance. How do we increase the activity tolerance of a patient who needs oxygen, who doesn't want to move because they're short of breath? Well, we start small and we build our way up. We keep them on the oxygen. We do bedside activities. We get them to engage in either just moving their lower extremities, standing at the bedside, marching in place, walking around their room. And we do these things consistently throughout the day and each day of the week. And we set goals each week. Okay, for the first week, if we're implementing activity tolerance management for a patient, then the goal would be to have them stand up for 1 hour a day. And we would just stand with them and talk, or collectively, so 20 minutes we come and stand with them and talk. They stand and brush their teeth. We make them stand and do activities that they may normally be doing sitting down. And what this is going to do is it's going to increase their confidence on their feet. Then once they have some confidence on their feet, they've been on their feet for an hour a day for 1 week. We move to step two and we increase the stand time, and we also add a walk length. So we want them to walk 10 feet within those 2 hours of standing. So not only do we have them standing, but we have them walking. And it's slow, progressive, but it keeps the ball rolling forward instead of standing still and then rolling backwards. And that's what the most important thing is these patients will need a lot of motivation and assistance and monitoring, because as we saw in the video I showed you guys in the excerpt from the video, where she said it's how hard it is for her to breathe. It feels like there's tape over her mouth and her nose, and there's a small hole uh, from the mouth where she is supposed to breathe from. So it is very hard for them to breathe. So they're going to need a lot of our help. So we talked about the effects that the disease has on the patient. And now we're talking about the management objectives, our care goals, what they should be for this patient. Now, do note in the bottom here, patients with COPD have a higher risk of acute cardiovascular events, and around 30% die from cardiovascular events. And that's just again to highlight the level of comorbidity that is associated with COPD because of the inability to move, because of the shortness of breath, because how it increases the risk for mortality and obesity. So it is very important that we monitor and manage these patients to help them become more healthy. So if I am taking care of a patient who has uh, COPD, and I'm meeting them for the first time, and I reviewed my care goals. Okay, for this patient, my care goals, I need to do something to relieve their symptoms, to prevent disease progression, to reduce the risk of mortality, to increase their activity tolerance, and to prevent and treat complications of the disease. Okay, so now I've reviewed my care goals and I'm going to assess this patient. what should you assess on a patient who has COPD? Well, it's very easy that we're going to say oxygenation. That's very important. We want to know how well they are oxygenating. And remember, normal levels 94 to 100%. Sometimes doctors, if the patient has an advanced stage of COPD, they may allow for the oxygen level to be 90, 91. Sometimes I've seen as low as 88. The doctor will allow the patient to saturate at a lower level because the patient has an advanced stage of COPD, and normal oxygen levels for me and you isn't obtainable for them at this point in their care, but maybe with some aggressive treatment, it will be. So the doctor allows for that oxygenation level to be below 94. So be mindful of this, because this is something that the doctors may do. So be mindful and look out for that. When you are assessing your patient, know what the patient's normal is. Now, breath sounds. If the COPD patients have narrowing of the bronchial tubes, so what that causes is airflow, the air has trouble flowing through, so that causes wheezing sounds. So we need to note whether that patient's wheezing sounds are normal for them, whether they are a bit more pronounced on this day, or whether they have resolved. We also need to note the patient's breathing pattern, their respiratory rate. Are they breathing normal? Are they breathing too fast, too slow? Are they using accessory muscles? Um, are they hunched over? As this guy here, we see him hunched over the table trying to catch his breath. And we also want to note the depth. Is the patient taking shallow breaths, very deep breaths? Um, are they breathing pursed lipped? What's going on? Everything we want to assess respiratory wise for this patient, and it's very important because not only is this going to help dictate our care of the patient for that day, but it's also going to let our other healthcare workers know whether the interventions that they're using to increase this patient's um, quality of life and manage their disease, whether those interventions are working and how well they're working. So we want to make note of all of these things. Also, we talked about COPD patients um, and how they have excessive phlegm. So we want to note their cough pattern, and we also want to know if they do have phlegm. What's the consistency of that phlegm? The amount and the color. Patients with COPD are more prone to getting respiratory infections. So we need to see if it's just clear, white, thick sputum, or if it's taking on a yellow, green, or brown tinge to it. So we can anticipate and let the doctors know, use different interventions to make sure that this patient doesn't get a full-blown respiratory infection, and we can treat it early. So every time you assess your patient, you should ask them, do you have sputum? What color is it? They're going to want to show you. That's fine. Um, but we need to make sure that we're looking at taking note or asking the patient about their sputum. Okay. So, daily weight. This is also important for patients with COPD. We need to know whether they're gaining or losing weight because this could be an indication of edema that's developing with these patients because patients with COPD, as I said in the previous slide, are more prone to develop acute cardiovascular events. So we want to know if this patient's COPD for some reason is affecting their heart, and now they're developing into respiratory or heart failure, and they're not pumping correctly, and so they have excessive fluid buildup or edema that's going on. So we want to make sure that these five specific topics that we are including in every assessment every time we check on our patient. And then here, this diagram here just goes to show in a little bit more detail of what we just talked about. So these patients have frequent respiratory infections, wheezing, chronic cough, shortness of breath, prolonged expiratory time. They have bronchitis, so they have increased sputum, digital clubbing. Um, so, and they're thinner in appearance sometimes. Now, nursing care and considerations, do's and don'ts. Do's and don'ts. What should we do? What should we not do? So, what should we do for a patient who has COPD? The first thing, the biggest thing, is we should reduce exposure to cigarette smoke and outdoor pollutants. This could be they can't be too close to flowers that have a lot of pollen and a strong smell, chemicals that are indoor. If the floors were just mopped with some type of cleaning agent, or if they're cutting the grass outside the facility, please do not take your COPD patient outside. If there's a lot of dust or debris in the area, or even sometimes if there's been a fresh rain in the morning and the dew on the ground, it's just creating that smell. All of those environmental changes can have a significant impact on your patient, and that could be what triggers them to have a COPD exacerbation. Now, it may not be severe, but it'll be a COPD exacerbation nonetheless, and it will make your patient uncomfortable, and it'll make your walk back to the facility or wherever, somewhere safer, somewhere that is safer for the patient, quite a scary journey. Um, so we want to reduce exposure to these pollutants. Also, we want to encourage breathing exercises. So taking deep breaths, pursed lip breathing, coughing, even if the patient doesn't feel like they have to cough. All these things are exercises for the lungs that are going to strengthen, that are going to that are going to get the juices pumping, if you will, inside the lungs, help loosen up the phlegm that may be inside of the lungs, so the patient can expel it when they get a breathing treatment, or if they can cough it up on their own, that's great too. Also, smoking is, as if you remember, one of the lead. Uh, it was the lead characteristic of our COPD patient, is a smoker, whether they're former or current. So if you're taking care of a patient and they haven't quit smoking yet and they have COPD, or you believe that they may have COPD, as evidenced by these type of symptoms or effects, then the first thing and the most important thing is you need to get them to stop smoking. Um, that is the most important thing. So, smoking cessation, you need to encourage them, let the doctor know, offer a nicotine patch, offer anything that will help them to quit smoking. Also, positioning the patient upright. Um, Even when they're sleeping, you want to make sure that their head is adequately elevated, um, because we want them to be able to breathe and not to become short of breath. And if, as our example COPD patient said in the video, Jan, if she said it feels like she can't breathe, we don't want them lying flat. We want their head elevated, to always allow oxygen to flow in and out as best we can for these patients. Now, what would be our don'ts in our nursing care and considerations for patients with COPD? What's something that you don't want to do? You don't want to allow the patient to not exercise. That's something we don't want to do. We don't want allow the patient to say, "Hey, I'm short of breath. I don't want to move around today." That's not acceptable. But at the same time, we want to be careful when we stand them up. If they say they're short of breath, we want to have oxygen on standby, or oxygen connected. And we want to perform our assessment before we take them for a walk or to do an activity. So we have a gauge of whether they're at their best or whether they're at their worst or whether they're somewhere in the middle. And this will help us decide whether we're going to push them to their goal, whether we're going to allow them to meet their goal halfway today, or whether they're feeling good and today may be the day we meet and surpass our goal. So you don't want to allow the patient to not exercise because they're fatigued, because that's just a part of the disease. They're going to be short of breath, they're going to be fatigued. But in order for us to improve their quality of life and to improve their ability to breathe, we need to push them to exercise even when they're short of breath, because we know that they're short of breath, we know that they are fatigued, but it's the only way to improve their symptoms, is to have them exercise. So that's a big don't for me in patients with COPD, is don't allow them to not exercise. Now, the next one is don't allow the patient to drink coffee and plenty of coffee and tea and say that, oh, that they contain water. Um, so I don't need to drink water because I've drank a lot of tea and coffee. No. Patients who have COPD, as we talked about, they have an excessive amount of phlegm. So the best way we can help them outside of breathing treatments is to get them to drink a lot of water. Now, what water is going to do, as you may already imagine, is going to eventually get into their bloodstream and thin the secretions that are coming in the lungs, so that they can expel them more readily, easier. So, drinking coffee and tea, those are good, but drinking water is the best. So, we want them drinking a lot of water, not just a lot of coffee and tea and telling us, oh, they have water in them. It's the same thing. No, it's not the same. So, third, don't is allow the patient to skip vaccinations. It's important for everyone to take vaccinations, especially if they're living in a community type of environment. We want to make sure that everyone has vaccinations so there's not some type of a breakout. But specifically, your COPD patients, we need to educate them and let them know that they are prone to respiratory infections. And that's very important that they get vaccinations because they already have a respiratory disease. And if they get some kind of bacteria inside of their lungs, it's going to be very difficult for them to recover. And it's going to be very difficult if they do recover to restore uh, their lungs to some type of level where they can enjoy more quality of life. And last but certainly not least, we don't want to forget the oxygen whenever we're traveling outside with the patient. Don't forget the oxygen, even if this patient is never short of breath, even if this patient is a fighter, is very strong, very courageous, wants to walk outside, hasn't needed the oxygen in weeks. You want to have the oxygen with you because you never know. And that's just being safe. That's just being smart. You want to have oxygen with you. You want to have a wheelchair with you because if they say they're short of breath and they need to sit down, they need their oxygen. Patients with COPD, as you can imagine, being short of breath, you get very anxious if you feel like you can't breathe. And that only functions as a downward spiral that keeps the patient thinking that they're short of breath, thinking that they can't breathe, and it only makes them breathe faster and expel more oxygen that they can't bring back in as quickly. So, these are our nursing care and consideration do's and don'ts. Okay. Now, what more specifically are the limitations of a patient with COPD? Breathing. It might seem odd, but exercising when you are short of breath actually improves it. We just talked about this. Exercises strengthen your respiratory muscles, which can make it easier to breathe. So, the best, one, not the best, but a very good suggestion for you to make to the patient, to the doctor, to the residents, advisor that they're living in, that you're working at, is pulmonary rehabilitation. And what this is not everyone will have this, but this is a good because it educates the patient and offers exercise classes that teaches the patient about their lungs, the disease, and how to exercise and be more active with the disease, and therefore decreasing their shortness of breath. Because as it says on the top of this slide, It might seem odd, but exercising when you're short of breath actually improves it. And also, it gives you that confidence that, hey, yes, I was short of breath, but I still walked. I still made it back to my bed and I didn't pass out. I made it. I'm okay. So it gives them that confidence. So it's important that we push them and show them the limitations and show them that they can reach those limits and everything's going to be okay. Stretching. This is a good exercise that we can do with our patient, whether they're sitting down, they're standing up, and it's called stretching. Not so much of stretching as if you're about to go for a run or exercise in the gym, but this is exercise for the lungs specifically. So, stretching means taking in a deep breath and holding it, encouraging them to hold it in as long as they can, and then blow it out. And then also at the end of the blowout, I like them to blow at the end of their expiration, at the end of the full expiration of the breath. I encourage them to blow out just a little bit more to fully contract those alveoli who have lost their elasticity. And this is like exercising them to kind of get it back, to fully empty those lungs so they can take in another big breath and expand the bronchial tubes and the alveoli as far as they can. So that's stretching. Now, this is what is most common, and what I've been kind of reinforcing throughout this presentation is aerobic exercise, kind of walking around with the patient. How, so you may have asked yourself, how long or what is a goal time for this patient? How many times a week and how often? So try and do some type of aerobic exercise with the patient for about half an hour, a few times a week. But there isn't a one shoe fits all application. So if your patient can't do in a half an hour and can only do 15 minutes starting out, that's okay. If they can do more, that's okay too. We want to make sure we individualize the goal, time, and level and intensity for our patient. How do we know that? What their goal time should be? Well, we use the assessment that I talked to you guys about. The oxygenation, we assess where the oxygenation level is, their breathing pattern. Are they having a lot of sputum? What is their breath sounds like? And we use this information to, as I talked about, create our objective goals for the patient. So we use all that information and then we decide what is the best goal for this patient. Or maybe this can be your standard. You see how they perform for half an hour and you either increase, decrease, or step up the level of intensity. So, aerobic exercise. And last but not least, resistance training. Now, resistance training, this is maybe for the patient who uh, has gone through some aerobic exercises and stretching, or maybe this is something that the patient wants to try. So it makes your muscles stronger, and specifically, it helps get your lungs strong as well. It involves weights more commonly, but you can use the patient can use their body as a weight, and this is just as effective alternative. So, what would be an example? An example of resistance training for a patient with COPD would be having them hold their arms out, having them hold if they have a small weight at your facility, or just holding their arms out, holding them up, doing pumps with their arms or with their legs, holding their legs out, um, putting their arms above their head, and maybe you putting your hand and providing some resistance on their hands to make it difficult for them to keep their arms up. And that could be our resistance training. And this is going to strengthen their muscles, which in turn is also going to help strengthen their lungs. And this is how we're going to break through the limitations that COPD has placed on their breathing. So, this is just some examples of different things you can do with your patient. So, mobility. COPD has a significant impact on patients' mobility. While mobilizing a COPD patient, you should always remember to be prepared and be mindful of the patient's breathing status. Why? Because it's very common for individuals with COPD to feel nauseous, to feel lightheaded, dizzy, to have chest pain, and to have anxiety when it's time to help them to perform some type of mobility. So, what is important to remember to make sure we're safe, our patients safe, we're happy, our patients happy, and we're just going for a walk outside their room, down the hall, to the cafeteria, to the bathroom, where have you. We want to help our patients stand up because you attended my presentation. I told you how important it was to get this patient mobile, to help them exercise, to push them past their limits. And so that's exactly what you did. But there are certain things that you need to know before you take your patient for that walk and even during that walk to keep you guys safe. So I have those listed here. And first, you want to perform an assessment, not a full head to toe assessment, but specifically the respiratory assessment for a COPD patient that I keep referring back to this slide. You want to know what your patient's normal level is for their oxygenation, how their breath normally sounds, what their normal breathing pattern is like, sputum characteristics, and daily weight. So, once you know those things and you perform your assessment, then you want to make sure that you've planned out in your mind where it is you want them to walk to. Now, on that walk to the end destination, there should be a place to sit or a place to rest or lean. Or maybe you went ahead and measured how many feet it is to that end destination. And every so many feet, there is a chair. And that's where you're going to tell your patient, okay, to that chair, and we're going to take our first break. Okay, stand up. Okay, to the next chair, we're going to take our second break. Okay, stand up. Now there are no more breaks. We're going to go straight to our end destination, which is the couch over there in the rec area. So you want to make sure that you have the path planned out, and you want to make sure that along that path, there are opportunities for the patient to take a rest if they need it. Next, bring supplemental oxygen. Remember that was under our COPD management do's and don'ts slide. You always want to have oxygen for your patient in case they become extremely short of breath or have some type of COPD exacerbation. Now, next, maybe you also need an assistive mobility device. We never know if your patient needs one. You want to make sure you have it. If they don't need one and they walk fine, then you don't need it. If it's your first time getting working with the patient, you should bring it regardless because you don't know. And then as you get to learn that patient, you can leave the assistive mobility device behind. But my rule of thumb is I just put oxygen on the back of a wheelchair and I bring the wheelchair with me wherever we go, or I have someone walking behind the patient while I walk with the patient. Teach and practice pursed lip breathing. This is something that I would want to do with the patient before we get up to walk so that if they do become short of breath or they're trying to catch their breath during our rest break on the way to our destination, they know how to execute this technique properly and they can use it to save their breath to get a more effective rest period and power through to reach our destination for that day's mobility activity. Second to last, we want to set a realistic goal and expectation for the mobility. So that is where I talked about assessing the patient, choosing a destination, counting the feet to that destination. Um, we want to make sure it's a realistic goal for that patient and not just a realistic goal in the sense that it's obtainable, but also a realistic goal in a sense that it's going to push them to a level that is going to require some effort because the only way for us to improve their ability is to push them to a level which may be uncomfortable for them. And last, but certainly not least, we want to inform a fellow staff member that we are walking somewhere, especially if it's later in the night or early in the day, or there's not a lot of movement going on, but that's the time our patient wanted to walk, or that's the time we had to get our patient up to for mobility. We want to inform a fellow staff member and let them know that you're walking your patient, let them know um, where you'll be, and let them know your end destination, just in case you need some help in the case of an emergency. So that is our COPD limitations, mobility planning. That's how we should handle becoming mobile with this patient. So next, we're going to talk about nutrition. So nutrition for this patient, it is important that we find the right mix of nutrients. Why? And I learned this just like you guys are probably learning this now. Just the right foods in your body can do a lot for you. And one of the things they can do for you is help you to breathe easier. Now, why is this? Well, the metabolism of carbohydrates produces the most carbon dioxide for the amount of oxygen used. Metabolism of fat produces the least. Now, remember, patients with COPD, they don't take in as much oxygen, but they do hold on to some carbon dioxide. So for people with COPD, eating a diet with fewer carbs and more fats helps them breathe easier. It's just that simple. We want them to eat more fat because it's going to help them breathe easier, because the metabolism of fat produces the least amount of carbon dioxide. So we're getting down to the foods to help our patient. We're going to give them every advantage to improve their life. And that's why I'm sharing this knowledge with you guys. So, what would the best diet be for this patient? I know you hear me say fats, but we're not just talking about them eating potato chips with 70% daily intake saturated fat. We're talking about healthy fats, healthy carbohydrates, because we can't just cut out all the carbohydrates. So we're going to do whole grain breads, pasta, fruits, vegetables. If the patient's overweight or if the patient's underweight. If they're overweight, then we're going to go with our weight loss option here, which is fresh fruits and veggies over bread and pasta. But of course, if we want them to gain weight, then we're going to offer those whole grain carbohydrates and fresh fruits and vegetables. Okay? Because the breads and the whole grains, they're going to have more carbohydrates, and those carbohydrates are going to help add to the patient's weight. Now, fiber. Patient needs 20 to 30 grams of fiber a day. And they're going to get that from those whole grain breads, pastas, fruits, and vegetables. But also, if they want a snack, we can offer them almonds, like nuts, seeds, and almonds, pecans, peanuts. They all have a substantial amount of fat in them as well. Now, for protein, it's always important that we offer our patients uh, strong, healthy, rich protein foods twice a day, preferably. And this is going to help maintain their muscles. And remember, the lungs is a large muscle as well, those respiratory muscles, the diaphragm. So, foods like milk, eggs, cheese, meat, fish. Those are all considerable food items for them to consume to get the level of protein that they need. So again, weight loss option, lean meats, low fat dairies. If they're weight gain option, proteins with higher fat content. So they can have the whole milk cheese and yogurt. They can pretty much grab it, have it, but if it's a weight loss option, then we need to make sure that it's low fat content. It's the lower milk option. And we're not going to offer them whole cheese. So we want to make sure that, remember, eating a diet with fewer carbs and more fats helps a patient breathe easier. Okay. Now, nutrition again, we talked briefly about this before, but drinking plenty of water is important because it keeps the patient hydrated, but also it helps to keep the mucus thin, which will help the patient with their coughing, and it'll be easier for them to expel the phlegm when they need to. Okay. Um, so caregiver tips. This is for you. This is for me. Um, we want to encourage the patient to rest before eating. We want to encourage larger meals in the morning if the patient is usually too tired to eat later in the day. Now, remember, these patients get short of breath. We saw in our video, in our example COPD patient, Jan, she was short of breath. She said she gets short of breath from laughing. So we know eating can be, we can imagine how eating would be a difficult task for these patients. So we want to encourage them to rest before eating. We want to get them the larger meals in the day, earlier in the day, when they're still fresh and haven't exerted too much energy. We want to avoid foods that cause gas or bloating because that's going to make them feel full. That's going to put pressure on their diaphragm and their lungs and might increase their shortness of breath. We want to encourage them to eat 4 to 6 small meals a day. We want them eating all day long, not just sitting eating one meal because they'll get too full, they'll get too sleepy, and then they won't want to partake in our exercises for the day. And also eating 4 to 6 meals, they won't be too full. The diaphragm will be able to move still very freely and enable them to breathe at their most effective level. And then if your patient does ever complain about drinking liquids with the meals and saying, oh, I don't want too much water, it's going to make me too full to eat, or we notice that they're drinking all of their water, but they're not eating any of their food, then we want to limit the amount of liquids they have with meals. So you maybe only want to give them 4 ounces and say, oh, you get the rest of the water once you're finished your meal, because we want them to eat more than we want them to drink, because we want to strengthen those muscles and we may want them to lose weight or gain weight. So these are the caregiver tips for nutrition when you're feeding your patient or you're trying to plan out their their diet for the day. Please take these into consideration. Avoiding too many beans that'll cause gas or bloating, paying attention to their eating habits, and making sure they rest before eating. Those are all very important. Now, this is COPD exacerbation. What is the primary cause of COPD exacerbation? Well, we see this picture here. It's supposed to represent environmental pollutants. And you see the cigarette here that can cause COPD exacerbation. And that's the second primary cause: smoking or exposure to environmental air toxins and pollution. Now, the number one cause of COPD exacerbation is bacterial or viral infection of the lungs or bronchial tubes. That is the number one COPD exacerbation. But smoking or exposure to environmental air toxins can cause COPD exacerbation as well. And remember, we talked about how important it was to make sure that we don't take the patient outside for a walk, or we don't take them outside of their room if the hallways have just been mopped with some type of cleaner. We want to make sure that they don't go in that patient's room and use too much cleaner, or the patient's outside of the room if they're going to be mopping or cleaning in the patient's room. We want to just be mindful of anything that's going on in our COPD patient's environment because it can cause COPD exacerbation. What does COPD exacerbation look like? It's just increased everything. So their shortness of breath is increased. It's even harder to manage. The sputum production increases. The sputum is even thicker, more purulent. And in worse situations, of course, if these patients have increased shortness of breath, increased sputum production, which is decreasing the amount of oxygen, there's going to be a change in the mental status because they're holding on to even more CO2, and it's even more difficult for them to bring in fresh O2, fresh oxygen. So we're going to see a change in mental status. That means they're going to be more confused. They're going to be complaining of dizziness, and it's going to look scary. Also, the first thing that the doctor will probably want you to do is to grab a blood gas, and the blood gases are just going to be worsening and worsening. So, what is the treatment for a patient who is having a COPD exacerbation? The first thing you want to do is grab some oxygen and make sure we give them some oxygen. The doctor is going to order either one or all three: bronchodilator, a corticosteroid, and an anticholinergic. A bronchodilator is going to be one of these medications here: albuterol sulfate, or levoalbuterol. And these are the brand names of those drugs there. And what that's going to do is it's going to help dilate the bronchial tubes, which is why it's called a bronchodilator. Now, a corticosteroid, it's either going to be prednisolone, or methylprednisolone. And those medications are going to decrease any swelling or inflammation. Remember, we talked about patients with COPD have just a part of the disease is they have inflammation of the bronchial tube. So this is going to help counteract that inflammation to hopefully help and just get a little bit more oxygen in and a little bit more CO2 out. And then an anticholinergic, uh, I'm not the best with pronouncing this name, but Atrovent is the name. And that's going to be given because it's going to thin the mucus, or hopefully stop mucus production, so the patient can catch up with getting rid of the sputum production. And that's just going to dry up everything, all the sputum and mucus productions in the body. So, what are medications? Those are all medications that patients with COPD take regularly as well. They take bronchodilators, they take corticosteroids, and they take anticholinergics. But these are the side effects that are associated with those drugs. So this is what we need to look out for and understand that it's just a part of the side effect, and it's not something crazy going on. Bronchodilators are known to cause shakiness or trembling in the hands or feet. They also are known to cause tachycardia, or a sense of a pounding pulse in the chest. That's normal. Corticosteroids, patients take them short term, which we would see in as the patient in uh, a COPD exacerbation would take short term, or it could be long term. So if they're taking corticosteroids short term, these are the side effects we're going to see: water retention, high blood pressure, sore throat, cough, possible infection in the mouth. So if the patient had a COPD exacerbation on Monday, we want to monitor them for infections in the mouth, a sore throat. We want to monitor for edema, and we want to keep an eye on their blood pressure as well. Now, if the patient has been prescribed corticosteroids for a long term, we want to understand that they are at a higher risk for developing diabetes, infection, osteoporosis, or cataracts. Anticholinergics, these symptoms, uh, nothing too crazy. Tachycardia, blurred vision, and urinary retention. Urinary retention because we talked about how anticholinergics, we give them during a COPD exacerbation because they dry up all mucus productions in the body. So, rightfully so, they probably dry up our ability to formulate urine. So, tachycardia, blurred vision, urinary retention. So, what else can we do as healthcare providers caring for patients who have COPD to make their life better? What else can we do? We talked about diet, we talked about mobility, we talked about the medications that these patients are taking. We talked about exercises that they can do. What else can we do? Little things matter. So, one of the little things I wanted to include was organizing the patient's living area. This can help your patient save energy when searching for what they need to complete their ADLs for the day. So maybe your COPD patient isn't very advanced. He or she can still move around independently. Organizing their living area can help them to conserve more energy, to feel more independent, and get things done. So we want to make sure we help them by organizing things for them. Look, I put all of your toiletries here. I put this here, and I put your shoes there. Putting things in plain sight and reminding them where they are so they don't waste any time or any energy or any breath looking for something. Maintaining healthy air quality. I talked about this over and over, keeping the patient away from smoke, fumes, pollen, and other toxins in the air. But if you want to go this step further, you can encourage the family to bring some type of air purifier. Put that in the room with the patient. Maybe put a safe plant in the room to help purify the air just a little bit more, just going the extra step, doing the most we can do to help these patients. And last but not least, we talked about these healthy habits, exercising with the patient 20 to 30 minutes a day. We talked about our well balanced diets, getting the patient to eat more fats because it's going to burn, because it's going to produce the least amount of CO2. The importance of smoking cessation and making sure that the patient is increasing their fluid intake. I would like to see them drinking 3 liters a day. So that's what we can do, little things to just go one step further to help those patients. So we have reached the end of our presentation today, and I'm going to test your knowledge with 2 questions. The first question being here, I'm going to read it with you. A nurse is admitting a patient to their facility. The patient is a 72-year-old male with a history of CAD, that's coronary artery disease, obesity, smoker, 1 pack per day, asthma, and dyspnea on exertion. The patient is showing signs of COPD but has not been officially diagnosed. Which of the following should be the nurse's first action in managing the patient's health to reduce risk of developing COPD? Is it A, consult physical therapy for an exercise regimen? B, consult the doctor for a nicotine patch? C, consult the dietitian for a nutrition plan? Or D, consult the doctor for a bronchodilator? I'll give you a second here just to look through the answers. Um, what would be your first action to make sure this patient doesn't develop COPD if they already have it? Your first action should be consulting the doctor for a nicotine patch because we talked about how smoking cessation is the number one way is the number one thing we should be doing for patients who have COPD. And this patient, from the sounds of it, is at very high risk if he does not already have COPD. So this is the most important thing that we can do for this patient to keep them from developing this awful disease. Question 2. A nurse is caring for a patient with COPD who routinely has trouble completing their meals. Which of the following is the most appropriate intervention for the nurse to take to make sure the patient maintains an appropriate nutritional intake? So, what is the most appropriate intervention for the nurse to take to make sure this patient is eating what they're supposed to be eating? Should we A, reduce the fluid intake from 3 liters to 2 liters? B, encourage the patient to only eat proteins? C, take the patient for a walk before meals? Or D, restrict the patient from drinking fluids at all until after meals? So, the most appropriate intervention for this nurse to make sure their patient with COPD is completing their meals would be D, restrict the patient from drinking fluids until after meals. You may have guessed C, which in any other disease would have been a great guess. But I talked about how patients with COPD, we should allow them to rest before eating meals because they're so prone to shortness of breath. And I talked about our COPD patient, Jan, who we watched a video on. She became short of breath simply laughing. So we want to make sure our patients rest before they eat so they can use all their energy and save all their breath to complete the meals. So, course review. By now, you should understand what COPD is and how it affects the respiratory system. We talked about the narrowing of the bronchial tubes and the decreased elasticity of the alveoli. You should also be able to discuss and understand COPD signs and symptoms, which you can, because we talked about how patients with COPD are short of breath, lightheaded, activity intolerant, and they have increased phlegm, among other things. You also should be able to identify limitations of COPD and corresponding nursing considerations, which you can, because we talked about mobility, we talked about activity, and we talked about diet and the different nursing considerations that you should be implementing into your practice when caring for patients with COPD. You should also be able to discuss treatment options for patients suffering from an acute COPD exacerbation. We talked about the three types of medications, and we also talked about the side effects of these medications that the patients take. And even for corticosteroids, we discussed the difference between patients who take corticosteroids long term and short term. So that brings us to our last objective, which identify nursing interventions to improve patient overall daily life and disease state. We talked about several ways we can do this. Even in our last slide, I gave you an additional tip here: organizing the living area, exercising, fluid intake, making sure we maintain healthy air quality, and well balanced meals. We can't forget our well balanced meals. And I gave you that detailed diet tip about making sure that the patient with COPD is eating more fats because that will help with the CO2. But of course, talk with the dietitian first. But that's just another step further we can go into making sure we improve these patients' quality of life. I want to thank you for spending the last hour with me. Again, my name is Deontay Marquis. I'm a family nurse practitioner in Southern California, and I want to thank you on behalf of my ALF training for staying tuned, for choosing us today. And I hope that you've taken away everything that we offered and will implement them into your care to help care for these patients. Have a good day. See you next time.